So we're going to be talking today about Medicaid eligibility for people age 65 and over and people with disabilities who have Medicare in New York State, and talking about some big changes that are on the way. So I'm director of the Evelyn Frank Legal Resources Program, and our other speaker will be Anna Ariana, who's a staff attorney with our program at NILAG. And NILAG is a legal services nonprofit. We provide a lot of different legal services, from tenants' rights to domestic violence, and our own specialty is Medicaid and Medicare, with the specialty on long-term care advocacy. And that's what I just said. Please take the link in that slide before, nyhealthaccess.org. When you get your slides, it's just www.nyhealthaccess.org, and we have tons of information there for you to keep abreast of these changes. So today we're going to be talking about if someone has Medicare, why would they need Medicaid? And how are they different? And then we're really going to get into the nuts and bolts of who is eligible and how is that changing. We're focusing on community Medicaid. We won't be talking about the nursing home rules that are somewhat different. So let's just compare Medicare and Medicaid. When we have new staff and volunteers who come to us, this is the first thing they need to learn, because the programs sound so much alike, but we know that they're very different. So first of all, there's the financial criteria to qualify. Medicare does not have an income test or a resource test. You can be a multimillionaire and get Medicare. But you had to have in your past have worked with on the books work, so that Medicare tax was taken out, and that's it could be you or your spouse, and sometimes your parent if you were a child with a disability. So you have to have that sufficient work history. There is an exception to that. Some people 65 and over, let's say they're on SSI and they don't have a work history, so they don't qualify for free Medicare, but the state will buy them into Medicare if they meet the immigration criteria. On the other hand, Medicaid is a poverty program. It depends on having low income and low resources, and we'll talk more about what that means. And those rules are complicated. They're not the same for everyone. It depends on your age. People under 65 and 65 and over are treated very differently in Medicaid's eyes. So these are just really key elements for you to factor in whenever you're counseling a client. It's always going to be, are they 65 or are they under? And if they're under, do they have a disability? Because without that, you can't even begin to know whether they qualify for Medicaid. To get Medicare, you have to be 65 or older, or have received Social Security disability for 2 years, with some exceptions. Whereas Medicaid is really available at any age, in any situation. It's not limited to people of any particular age, but as I said, the rules change depending on your age. In terms of what these insurance programs cover, those are pretty different. Medicare focuses on primary care, acute care. It's very limited it doesn't cover dental care, eyeglasses, hearing aids, medical transportation, and it's very limited on long-term care. We'll look at that. And there is significant cost sharing, premiums, deductibles, co-insurance. Medicare can be very expensive. On the other hand, Medicaid is very comprehensive. It covers all acute care, primary care, and long-term care. And it fills in those gaps, and we'll talk more about that. Now, many people have both. They have Medicare and Medicaid to fill in those gaps, and they're called a dual eligible. So let's talk more about the gaps. Long-term care, that's the main reason clients come to us for Medicaid. They might have Medicare, but so what does Medicare cover in terms of home care? You've all heard of the visiting nurse. That's very limited. A nurse who pops in after you were in rehab or had surgery and they're changing your dressing or taking your blood pressure. And usually that's short term. Not always, it can be longer. And that can come with a home health aide, but it's limited. It's only up to 20 hours a week and usually much less. I mean, nowadays it's more like 3 hours a week because the reimbursement for these services have gone down so much. It can also come with a skilled therapist, a physical therapist, an occupational therapist in the home. And now those are skilled, but the aides are considered unskilled. And there are very strict criteria for this. You must be considered homebound, which has a special definition in Medicare. Medicaid doesn't require you to be homebound to get home care, and it can cover up to 24/7 home care as long as it's medically necessary. And boy, do they put you through the ropes to prove what's medically necessary. And our colleague Peter Trevisky will be doing a session on home care later in this series. So it covers a lot of unskilled care, personal care, which in New York City we've used to call home attendant, the Consumer Directed Personal Assistance Program, or CDPAP, private duty nursing, and both Medicare and Medicaid cover home hospice. So Medicaid has a much more comprehensive home care program. For rehab, Medicare covers only up to 100 days, and then there's strict conditions on that. Some people call us, but Medicare stopped after 19 days. Yeah, they don't have to cover 100 days. They can cover up to that if you meet the criteria, and that will be covered in a different Medicare session. Maybe it already was. And there's stiff costs after the first 20 days, which are generally free. Warning that in some Medicare Advantage plans, those might not be free. You have to look at the details of what a Medicare Advantage plan charges. But there's a copay of almost $200 a day after day 21. So that's expensive. Nursing home care for Medicaid is comprehensive. Long-term nursing home care. Many people are in nursing homes for, permanently, and Medicaid can cover that. They do have to contribute most of their income, and they have to meet the asset test. And then there are transfer penalties and things which we're not going to go into. Assisted living is not covered by Medicare at all, but there are some assisted living programs that are covered by Medicaid called ALPS, assisted living programs, but it's not a lot of the ones that you may see advertised, the big national change like the Atria, those are not Medicaid ALPS. So you have to make sure if your client needs Medicaid assisted living to check to see if they are, there is a state list on the State Department of Health website where you can look that up. Okay, and Medicaid covers a bunch of things that Medicare does not cover: dental care, audiology and hearing aids, optometrists and eyeglasses, and medical transportation, even when it's not an emergency, just because the client can't travel to the doctor because of their disability. So these are all things that someone might want. Now, aside from these extra services, Medicaid helps fill in the gaps for Medicare. As I mentioned before, there's big out-of-pocket costs for Medicare. The Part A deductible, you spend one night in the hospital and the minimum charge is $1,556. That's the deductible. So if you're eligible for Medicaid, it can cover that. We talked about the skilled nursing facility co-insurance. Now, Medicare also charges under Part B 20% of the approved charge for doctor's visits, outpatient care, psychiatrist care, ambulance services. So that 20%, if that's a high charge, that can be a lot. I have a client now, the 20% of her bi-weekly infusion is $4,600. She's charged that every 2 weeks for a Part B infusion for a rare genetic disease she has. She can't afford that. So Medicaid can fill in the gaps. With Medicaid, you also automatically get extra help with Part D prescriptions. So that just comes with it, which is, a huge help. A companion program to Medicaid is the Medicare Savings Program. Right now, not everyone in Medicaid is eligible for the Medicare Savings Program because let's say they have Medicaid with a spend down. And if their income is over the MSP, Medicare Savings Program limit, they might not be eligible. We'll talk about that a little bit more. But if you are eligible, it's a great benefit. It pays that Part B premium. If you have Quimby, it also pays for that hefty Part A and B deductibles and co-insurance, and you automatically get extra help with Part D prescription drugs. So there's a quick question. How do we assist clients to apply for the MSP? They apply, if they have Medicaid, they should be screened for it anyway. HRA has the responsibility of screening for it. If they don't have Medicaid, they file the application for the MSP with the New York City HRA. If they only want the MSP, there is a separate application. We can give David the link to download that. That is a simpler application because there's no asset test for the MSP. But if they want Medicaid and the MSP, it's all in one. Just use the Medicaid application, and that is automatically considered a request for MSP. So more on filling in those financial gaps is extra help, which is with Part D, which is a huge benefit. It covers the Part D premium up to $42 and change a month. I've heard that next year that the benchmark rate is going down a little. It's like 30 something that it will pay. But it's still a big help. It reduces your co-payments to $395 for generics and $985 for brand names. There's no Part D deductible if you have extra help. And even if you have Medicaid or MSP for just 1 month in a year, you get extra help for the entire year. And if that 1 month is at the end of the year, let's say someone gets Medicaid now in September, October, they not only have extra help for the rest of 2022, but they get it for all of 2023 just by having Medicaid for 1 month. So that's a fantastic benefit. There's also EPIC, which I think you all are familiar with, and that will also pay the Part D premium. And if you have extra help and EPIC, you get an extra premium paid. If your premium is more than the $42.43, they'll combine them and subsidize even a higher cost premium. All right, so now let's get into a little bit more about who is eligible for Medicaid. And as I mentioned, it depends on your age. And if you're under 65, are you disabled? So those under 65 who do not have Medicare are in a category we call the MAGI category. And MAGI stands for Modified Adjusted Gross Income. And if you do your taxes, that might ring a bell. It sounds like a tax term, and it is a tax term because this type of Medicaid uses income tax rules for a lot of the terms and for how income is calculated. But look at those income limits. $1,563 for a single person and $2,106 for a couple. And if you probably know that that's a lot higher than the income limits for seniors and people with disabilities. It is not intuitive. Just because you have two people living in a house, whether you can use the household size of 1 limit or the household size of 2 limit. Get help before you make that assumption. These are tax rules and they are not intuitive. There is no spousal refusal in this program. So I know DFTA agencies help a lot of people between the ages of 60 and 65. So if they are not on Medicare, this is the Medicaid program for them, which is great because it is the higher income limit. But they can't use spousal refusal. And there is no asset limits. And someone's asking, is that a new rule? No, it's not new. This has been since 2014. This is all under the Affordable Care Act. This is the ACA. And even before that, in 2010, New York State changed our state's Medicaid program to lift the asset limit for this group. So when someone comes into your door, you ask them, are you under 65? And if so, are you on Medicare? And if the answer is, yes, I'm under 65, and no, I don't have Medicare, this is the program for them. Now, we don't suggest that you apply for them yourself. We suggest you call community health advocates. They are a navigator, and they can help. Oh, great. David says they're presenting here. They can help people apply. It's a different application system. It's online. There are different rules. You don't use the paper application that many of us are used to. So for me, I say, don't try this at home. Have them do it because it's even different than what we know. Even though we're experts, I wouldn't file an application online for this type of Medicaid. And the beauty of it is it's instantaneous. You get approved that day and you have Medicaid that day. That's so different than the other type of Medicaid for seniors. So you want to do it right, make the referral to CHA, Community Health Advocates. Now we go to non-magi Medicaid. All right, and that's the one that I think us at NILAG are more familiar with because most of our clients are elderly, 65 and over, or they are disabled, receive SSD, and have Medicare. So for them, the income limits are only $934 now, but stay tuned, they're going up. That'll be in another slide or two. And the couple limit is $13.67. But the good news is that people can use a pooled trust to bring their income down below these limits. And there's a pretty strict asset test. It's not as strict as some states. Many states, you're not going to believe what the asset limit is in many states. $2,000. That's it. The same as what's true for SSI. So at least in New York, we have a higher asset limit, 16,800 and more for couples, but it's going up next year. We're very excited about that. Public Health Solutions has a contract with the state to be a facilitated enroller to apply for people in this category. And, you know, if you don't do applications in your organization, then you can refer them. Now, they don't do pooled trust. They're not going to enroll a client in a pooled trust. But if you hand them all the trust paperwork and all the disability documents, and my colleague, Taya Bishop, is going to be talking about what all is involved in setting up these trusts, they will file that whole package with the Medicaid application, but they won't help you prepare it all. But that's a great service to think about. So let's drill down a little bit. So what is income that's under that income limit? Well, it's everything. It's earned income, which could be wages or, you know, self-employment benefits. It's unearned income, which is Social Security, pension, and VA benefits. It could be a one-time payment, like an inheritance or a lawsuit settlement. And it could be something considered recurring, like an IRA distribution. So if you have an IRA, it's okay. You don't have to cash it in, but the distributions that you're required to take count as income. And the way Medicaid does that is, let's say you take a distribution once a year. They'll say, that's nice, but we're going to divide it by 12 and add that 1/12 to your monthly income. And so that will add to your spend down, okay? Keep in mind that Medicaid counts gross income, not net. They don't care what union dues are taken out of your paycheck, what the FICA is, the federal taxes. They count gross, but there are certain deductions. You always have to calculate, just if someone gets paid twice a month, you have to add those checks up to figure monthly income. We're going to get to IRAs in a minute, okay? They should be exempt, but if you follow certain rules, and Anna's going to get to that in a minute. So, but with earned income, there's some very good deductions in this type of Medicaid. As a work incentive, they take your gross earned income. Let's say Sally is earning $2,000 a month. They take only half of that is counted as income. And it's actually a little less because they disregard the first 65, then they take off half the remainder. So that sort of makes up for the fact that they don't look at net income. They look at gross, but then they only count half of that. So that's a great work incentive. They don't count what you have to use to pay your health insurance premiums. Those are deducted. They take off a standard $20 deduction, and that's $20 whether you're a single or a couple. A couple doesn't get 40, it's just 20. Some income is exempt. The stimulus payments were exempt. That pandemic unemployment compensation that ended quite a while ago was exempt. Interest and dividends on savings is exempt. And Holocaust reparations are exempt. And there's links to more lists of what income counts and what doesn't count. All right, so I love giving the good news. Here's the great news. January 2023, big increases in income and asset limits. So as we just said, since 2014, under the Affordable Care Act, the people under 65 have had MAGI Medicaid. And I didn't mention that the way their income limit is calculated, it's at 138% of the federal poverty line. And that's, so when the poverty line goes up, the income limit goes up. And no asset limit since 2014. This is Obamacare, it's the ACA Medicaid. But since then, you hit 65 or you are on Social Security disability and you get Medicare and you fall off the cliff. Suddenly, the income limit drops from 138% of the poverty line to around 85%. And that's welcome to non-magi Medicaid. So now you have a big spend down and now you have an asset limit. So what's changing? So the budget earlier this year, April 1st, they passed landmark increases. Now the income limit will be the same. There will no longer be a drop in the income limit when you turn 65. And the next slide will show you. Also, they increased the Medicare savings program limits so that QIMBY will now be the same as Medicaid. 138% of the federal poverty level will be the income limit for MAGI Medicaid under 65, non-MAGI Medicaid over 65, and QIMBY. And QI1 will be 186%. And they're eliminating the SLMB program. They just don't need it now that QIMBY is going up. So this slide will make it all concrete for you. So here's the limits. So you can see now that Medicaid and QIMBY are the same. I mean, that's a big increase next year for Medicaid from 934 to 1563. And for couples, 1367 to 2106. And the same increases for QIMBY. QI1's going up quite a bit. And the asset test is also going up, but not as much as we hoped. Talk about that in a minute, but at least it's going up to 28,000 and change for singles and 37,900 and change for couples. So these are big increases. Now, what's confusing to a lot of people is that they think that now that the MAGI income limits will be used for non-MAGI under 65, over 65, it means all the rules are the same. And that's not true. It's just the income limit that's changing. All the old budgeting rules will still be used. Like if your income is over those limits, you can spend down, or you can use spousal refusal if your spouse's income brings your income over the limits. Or you can use a pooled trust, which Taya Bishop will be talking about, if your income is over the limits. But many people who needed pooled trust before will no longer need them because their income will be under those new limits. And we think this is going to help a lot of people keep Medicaid when they turn 65. Now, this doesn't change nursing home budgeting. Those rules are going to be the same. You're really only allowed to keep $50 if you enter a nursing home permanently, and that's still going to be true. None of this is going to help that. All right. Now, the asset limit, we're happy about it, but we were disappointed because NILAG and other advocates asked the state to repeal the asset test. So it would be the same for people under 65 as over 65. And the reason we ask for this is that these rules are biased against people of color and against people who are lower income, who statistically are not homeowners. We know there's a lot of bias in the rules about who can get mortgages. There's redlining. There's historical reasons why a lot of people of color could not invest in homes. And the same thing with retirement funds. I can save in an IRA because my company, my nonprofit, they have a tax deferred annuity that I can save in, and they even contribute to. Now, a lot of people don't have these white collar jobs where you can save into those funds and then use them when you retire, and they're exempt when you retire. So you can read more about these if you look at our news article. It has all of our coalition letters with citations about the racial bias in these rules. Because when you think about it, someone can apply for Medicaid. They have a home worth $955,000, and they could have $1 million IRA. They can get Medicaid. But a tenant who has $50,000 in the bank is denied. So that's not fair. But we lost on that. We thought we were winning, but we lost. Instead, we got that slight increase. Okay, so now this change is in effect January 1st of this year. But unfortunately, there's no magic in Medicaid. Okay, they can't just suddenly get rid of everyone's spend down and reduce their spend down on January 1st. This has to be done through a mass rebudgeting using computers that are very antiquated. And the state has told us they are hoping that they can do a mass rebudgeting in January. But they might not be able to program these 50-year-old computers to do that. So we just don't know exactly how that's going to be done. What we do know is that the public health emergency is expected to be declared over around the end of this year, early 2023, which means that next year, when your clients get their Medicaid renewals, that's when they will be rebudgeted at the latest with the new standards. So we just don't know exactly what's going to happen with this. And we have links to where you can stay tuned on what's happening. But in the meantime, you can help make sure your client gets their renewal next year by telling HRA if they moved. They've got to get their address on file. And we have tips on that at this link. So, all right, so that bottom link, the Health News 90, is where we will post information on how they're going to be implementing these increases. All right, and any more tips we have. And you can sign up for our alerts, which will also let you know about that. Okay, so moving on. And now we're going to go into some more. So now Anna's going to take over. We're going to do myths and facts. So here's the first myth. My income is $1,700 a month. So it's well over the singles limit. So I guess I'm not eligible for Medicaid.
Well, Val, you're right. It's a myth. Luckily, we live in New York State, which is a spend down state. And you mentioned spend down a few times earlier, but we can dive into what this spend down is, which is also called a surplus, because even though you have a spend down or a surplus, you can still get Medicaid. So let's take an example, simple math through Mary's figures on her gross income and her health insurance premiums. Her gross income is $1,700. She has 2 allowable deductions, which you mentioned, her Medicare Part B and a Medigap. And then she has a $20 disregard, which you also mentioned, Val. So deducting those 3 items, her net income for Medicaid purposes is $1,322. So comparing that to the income limit of $934, there is an excess of $388, which we call in Medicaid as a spend down or the surplus. Just because you have a surplus or spend on doesn't mean you're not eligible. There are actually other deductions, special budgeting rules that are not simple. So if you calculate yourself to having a spend down, it pays to consult a Medicaid expert. You have our intake line that you could call. We have that information in the beginning, and we can repeat that towards the end of our presentation today. But for example, there's also spousal refusal that can help reduce your spend down. Val mentioned it a while ago, but we know this can be complicated for some of you folks. So if you wanna learn more, we have a link that we provided here in this slide, which you could access to in the library of DFTA later on. But also you could just call our intake line for some assistance regarding what these ways are to reduce your spend down. So more about that spend down from Mary. So we already know she has a spend down of $388. Oh no, says Mary, how am I going to get Medicaid? I want to get Medicaid. So there are ways she can still get Medicaid, and we'll go through them. I want to simplify things, make you hopefully retain what you're going to hear today. So at the risk of oversimplifying it, let me just say that for the pay-in program, I usually tell clients this is like going to the movies. What does that mean? When you go to the movies, what do you have to do? You have to pay for the ticket. And once you pay for the ticket, you can go and watch your movie. Well, there's something similar to that in the Medicaid program. If you want to get Medicaid, you have to pay Medicaid for that ticket. And that's the pay-in program, exactly like that. You will pay in to Medicaid $388. So it works like a monthly premium of some sort. The only thing, it's not an attractive option. Like, who wants to pay $388 as if you don't need every single dollar of that for your rent, especially in New York City? But we'll go into how to address that in a minute. The other way to meet the spend down is to submit medical bills that will offset that spend down. So for example, come October, beginning of October, you know you're going to have to pay and incur this medical bill for whatever reason. If it's at least for $388, you can submit that bill to the Medicaid office, and that meets your spend down for that month. We have another note here pertaining to those who enroll in a managed long-term care plan, those who need Medicaid home care. When that's the situation, when that applies to your case, you already have Medicaid, you're on the MLTC, you actually are billed by the plan for that spend down. So because this is a recurring bill, it works like the second route, which is incurring medical bills to meet the spend down. You will get billed by the plan, and this is probably going to be discussed in session 4, but it's going to not necessarily disqualify you from getting Medicaid, but you will get these bills. Now, let's go back to what do you do if you want to get Medicaid, but you have this $388 that's a spend down. You want to pay your rent. You have other bills to pay. So what's good is that in New York, you can join a pooled income trust. And as Val mentioned, this is something that will be taken up by Taya Bishop in part 3 of Medicaid. I suggest that you join us as well for that. But in a nutshell, what is a pooled income trust? Again, at the risk of oversimplifying, I say it's like joining a gym membership. When you join a gym, what do? You fill in simple paperwork. You have to maybe put in a little bit of money, like an annual joinder fee. The same with a pooled income trust. You do that, maybe a little bit more paperwork than going to a gym. But after that, you're a member. Monthly, you pay a fee. In the pooled income trust world, it may be $20, $50, thereabouts. There are many types of trusts that you can join in. So once you pick the trust that meets your approval, you will now start to put in your spend down into that trust account. And that allows you to get a BOGO, a buy one, get one. Why do I say that? I say that because when you join a pooled income trust, you don't only get Medicaid, but you also get to pay your rent, your utilities, whatever the $388 could be used for, you can do. And that's through the trust actually disbursing the amount you deposited, less its monthly fee, towards whatever you want them to pay, which in general will be for rent, for utilities. But if you have a credit card, you could actually have them also pay your credit card company. But just as a side note, this trust is not like an ATM machine. It doesn't give you back your money if you want it withdrawn. It can only pay third parties and for whom you want it to pay. So hopefully you got the idea that this is an option for people who have income above the Medicaid limits, but who need home care. That's why most people want Medicaid. They want home care, or those who want to be in the Medicare savings program. So more in session 3 on that, and that will be on November 1st, just as a plug. So what will Mary's spend down be though in 2023? As Val said, great news, because the limit you see here in red is going to increase to 1,563, given the same numbers that we looked at before, okay, and even without counting the $170 and change for Medicare Part B, Mary will now have 0 spend down. So if Mary needed to get Medicaid this year, maybe she'll just do the pay-in program, just going to give bills to Medicaid to meet the spend down. But come 2023, she doesn't even have to bother with any of that. And we specifically made this example whereby she doesn't even have to pay the $170.10 because the limits also for MSP have changed and have increased. And therefore, the benefit of that is that Mary's Medicare Part B will be paid through the state. So I think we tackled already the income test. What's income? How do you calculate what to do when it's excessive? Now we'll touch a little bit about Medicaid assets. like what is an asset in the Medicaid world. So we also call them resources, assets, resources, the same thing. This refers to cash, assets, or property that can be used to pay for living expenses. Val's already gave us a 2022 limit. It's gonna jump up in 2023, as you could see here. It includes your bank account, savings checking account. It includes life insurance policy, which have a cash surrender value. So that's pertaining to whole life policies and not term policies. If you have any stocks, bonds, mutual funds, if you have received a one-time lump sum payment, such as an inheritance or a lawsuit settlement, and you don't spend it within the month you receive it, it will be considered as a resource the following month. And any real property that you have other than the home, but note that we just want to make clear that when we talk about your home and you actually own it, you're not renting it, you own it, there is a limit as to the equity that you have into that home. And in 2022, that limit is $955,000 unless your spouse or a minor disabled child lives there. A side note on the life insurance with cash value, it is not counted or it's disregarded up to $1,500. The same with if you have a savings account for burial purposes, it's not counted up to $1,500. And then we also cite if you invest in a prepaid funeral agreement, that's not counted. And as Val mentioned, if you have an IRA or other retirement fund and you're taking regular distributions from that IRA, we're not counting the IRA in your resources. We're going to count the distributions in the income, but not the balance in that IRA.
Okay. And just to clarify one point, Anna is talking about people applying for Medicaid for home care, because then there's the equity limit on the home. But if that's not the reason you are applying for Medicaid, if you're just applying because you need help with all that Medicare co-insurance and you want dental care, then there's no equity limit on the home. It's unlimited. So that's only if for long-term care, which is the main reason why people come to us for Medicaid. But let's talk about another big factor, which is I'm not a US citizen. So I was told I cannot get Medicaid. Is that true?
So that is a myth, Val. I know we're running a little bit out of time, but I want to say that is a myth. Just because you're not a citizen does not mean that you cannot qualify for Medicaid, as Medicaid actually covers other statuses other than citizenship as listed here. Those are green cards, humanitarian immigrants, those under PRU-call, those who are in certain visas like business. And because we like leaving you with good news towards the end, we want to tell you that right now, people can get emergency Medicaid even though they're undocumented. And emergency Medicaid is a condition that after sudden onset has acute and severe symptoms, which if left untreated could place the applicant's health in jeopardy. That, as well as some COVID evaluation, is covered for these undocumented immigrants. But in 2023, for people over 65 and over, they'll be eligible for full Medicaid. So this is a big news, which we welcome. But we just want to say that if you are somebody applying for Medicaid, but need nursing home care, and you're undocumented, we suggest you consult an immigration lawyer because this could make you a public charge, which will affect your status. So With that, I'm turning it back to David, Barry.
Hi. So everybody, we are going to run over a little bit. I'm happy that we've gotten a lot of questions. You guys gave an amazing presentation in the short amount of time. Barry and I have been scouring the Q&A and the chat. There's lots of questions in there. For those that don't know him, I'm going to introduce him. Barry Langer. He is a retiree and he's a bill payer through the bill payer program. And he also hosts our live Q&A, and he has been collecting your questions along with me. And take it away, Barry. He will be asking
Sure,
your
thank
questions.
you. Very comprehensive, very complicated topics. You did a wonderful job. Some of them, Valerie, you've been answering as we go along. I may hit some of the top ones, and then David, I may ask you to jump in just because these aren't just straightforward, simple questions to a great extent. Let's start with the pooled. If you're in a pooled income trust, but now with the new Medicaid limits, you don't necessarily need that. What happens? What should you be doing?
So, well, the limits don't start until 2023. So don't do anything yet.
Mhm.
You know, we honestly haven't figured out our exact advice of what to do because, as I said, we don't know exactly when the state is implementing it. But what my tentative thinking is if someone is sure that they won't need a pooled trust in January, that they could stop contributing it. Stop contributing their excess income into the pooled trust in January and gradually close down their trust, spend down what's in there, because they'll still have a monthly fee, whether they put in income or not. So they don't want to just let any balance get dissipated by the fee. So, and then when they do get renewed next year, because everybody will go through a renewal, at that time, they'll no longer have to show I've been putting money into a pool trust because now their income is under the limit. But a caveat is there are people who are sort of on the borderline where the example Anna gave is someone who's wasn't in a Medicare savings program and was deducting her Part B from her income. Now, for some people in those that, you know, within $100, $200 of the limit, they're going to have to make a decision. Gee, maybe I'll stay in the pool trust because it's worth it for me to keep the Medicare savings program. So I don't want to deduct Part B from my income to reduce my spend down. I want to have the Medicare savings program, which means their check goes up $170, right? So I think for people in that range, there's going to have to be some counseling and decision making about, you know, what to do. But there are people who are just absolutely clear they won't need the trust, and I think they can stop contributing in January.
Excellent. Do you have any good references for people for help in forming a pooled income trust?
Not really. I mean, there's just not free services. We have great online information, and I think that's in some of the documents that will be posted. We have terrific information. If you're a social worker with a nonprofit, I urge you to use our materials online, and you know, we're always glad to help you, like sort of coach you the first time to learn how to do it. It's not rocket science, but you have to know the rules and you have to know how to do it. So take a look at our information, but for free services for enrolling, I really don't have any.
Okay.
Unfortunately.
So if somebody's been on Medicaid but they've had, for example, a home that's qualified and then they pass away, family sells the home, is there any payback to Medicaid requirements?
That's covered in Part 2.
Okay.
Come to our Part 2. We knew we couldn't cover everything in Part 1.
And I just have one more that I think maybe we'll cover, David, and then if you feel based on time, there are others you want to go to. But this question of IRA distributions, there are people, of course, over 70 and a half, and they are required to do RMDs. That whole issue of what's required related to the IRAs and exemptions.
Anna, you want to take that?
Yeah, I actually, Val, asked Ron this question not too long ago, and he said, so the answer to the question is, if the required minimum distributions comply with IRS rules in New York City, these distributions will satisfy the Medicaid rules as well. So what that means is, if, for example, you have this IRA account and that you're telling Charles Schwab to send you $100 a month because that's what you were advised was going to be sufficient for IRS purposes, that $100 will be the amount counted as part of your income. But the balance you have at Charles Schwab will not be counted as a resource.
So, and just to add one note, now people who are just aging in don't have to take distributions till 72, right? So then we tell a 67-year-old, sorry, you got to take distributions. And I said, but the IRS isn't making me, why should I? Sorry, you want Medicaid. Medicaid has its own rules. They don't use the IRS rules. And there were a number of questions in chat. Can I just let my IRA sit? No, you cannot, unless there's one time you can let your IRA sit. And that is if you're under 65, you have Social Security disability, and you're working. There's a special program called the Medicaid buy-in for working people with disabilities. And in that program, you're not required to draw out of your IRA, but that's it. Everybody else has to take distributions.
So David, I'll pass it back to you. We're about 5 after, and I think
Yes, we had a
I've covered
couple,
them.
we had
Yeah.
a couple specialty questions. I know Eric Hausman, who Valerie, asked you a question about the MSP in early 2023, if the
Right.
eligibility will be based on the 2022 FPL.
Right. I mean, look, just based on what they've done before, the federal government doesn't issue the FPL, federal poverty level increases. It used to not be till April. Now they've been moving it up to like late January. So what does Medicaid do? Because these programs depend on the federal poverty level, right? So historically what they've done is so that you have apples and apples, they look at your eligibility using your 2022 income and your 2022 federal poverty levels. But Eric, you're asking me what will DOH state do now with the increases? Wait and see. I don't know exactly. I'm not the state. So, I mean, I think they usually try to be fair and have people compare like apples to apples. We're just going to have to wait and see.